I'm Brendan Cooper. I'm a consultant clinical scientist in respiratory and sleep physiology at the Queen Elizabeth Hospital in Birmingham, which is a fabulous new hospital, PFI build, and has taken 2 hospitals and made them into one great big hospital, which works superbly because we actually all start to interact with one another, a little bit like you do here. So I'm going to talk to you. Hark the healthcare scientists sing, and I'm not going to sing, I can tell you that now, so don't be worried, about leadership, the Academy and you. The Academy is only about 3 to 4 years old. You probably think it's been around a lot longer. Certainly the constitutional representative professional bodies, some of them have been around for 100 years. And the Academy is really capturing all of that experience and making it into one voice, one organisation for all people who work in healthcare science, and that's you. I'm hugely privileged to be here because not only am I've been appointed as president, which is a great honour in itself, but I'm getting the opportunity to speak to the leaders of healthcare science in the Northwest and perhaps beyond that have trained here of the future. You are our future, and I'm really pleased to be here. And I've had a chance to chat with a few of you today, and I think you're having a good time of it, and we'll kind of build on that. I've just got back from the Academy Congress in Edinburgh. It was a weird thing, Sunday night, all day Monday, but very, very successful. We actually, for the first time, as healthcare scientists at an academy, we spoke to the Minister of Health. She actually spoke to us, rather, in the Congress. So, you know, that's like getting Jeremy Hunt to speak here in NHS England land. We actually got the Health Minister, and she's promised to work with the Academy to enable all sorts of change and use of scientists in Scottish healthcare, which is absolutely fantastic. We also launched the Academy's honorary fellowships, and whilst the process won't be quite complete, I'm delighted to say that one of your own, Helen Liggett, has been given an honorary fellowship of the Academy of Healthcare Science for the brilliant contribution she's done to the Northwest. So I'd just like to... And that could be you one day. So I'm going to go through what the Academy is, what does it do, and why is it important for you, particularly at this stage of your career. So how are we perceived as scientists? If you asked man in the street, woman in the street, they'd probably say, oh, well, they all wear white coats, they all have flasks with blue liquid in, that's very important, and they all are incredibly made up and neat for a Monday morning. They also might think that, you know, we're scientists, so we're a bit geeky, we're eggheads, we're nerds, we're weird, we're out of the ordinary, and there's all these kind of images of what scientists are and a bit odd. No, all the others are odd. We're the scientists, we're the smart ones. But actually it's very, very cool to be a scientist. And the Northwest's very own Brian Cox, we've got Keith Isnt, Ian Barnes, who are leaders in physics and healthcare, biomedical science in the UK. But Einstein is a scientist. He's really cool. He's a really cool guy. That's an image that people would like to be, that smart. And Doctor Who, that, you know, younger people and people of all ages actually follow. He wasn't a medical doctor. He's a scientist. So there are lots of good images there and good concepts that science actually isn't weird, isn't odd, is really important. And you might have noticed in all those images there, they were all men. Most of our healthcare scientists are women, and most of our leadership isn't yet women. So that's something the women in the room need to be thinking about. But, you know, we need to get the public to understand that healthcare scientist isn't the image that they've got in their mind from the press and from films and everything else. We're a very young, vibrant, of all backgrounds working in science. So the purpose of the Academy is to have one overarching body for all the 52 and more professional bodies in healthcare science. and to work alongside the specialist professional societies, not to replace them, not to be an instead of, it's an add-on. If we put all the professional bodies together and all the skills and the standards and the educational standards and everything that they do, the academy almost, because of that, kind of floats us on the top of that as healthcare science. We all are healthcare scientists, irrespective of our area of either biomedical science, physiology, medical physics and engineering, or even bioinformatics. And then the subspecialties, no, we are all healthcare sciences. That's what the public sees. That's what the patient sees. And we want to be recognised and respected as one of the key clinical professions, not just individual professional bodies, all of us. So when you hear Radio 4, when you hear the press, when you hear debates on television, on the radio, they don't just say doctors and nurses said today. Doctors and healthcare scientists said, doctors and healthcare scientists published, or whatever. Ultimately, the whole point of the academy in terms of the regulation side, as with all regulatory bodies, is protection of the patients we serve. It's not for us, it's not a little badge to say, aren't we clever? No, that's what our degrees and our fellowships and everything else is about. Regulation is only about protecting patients, and we can only protect patients by having brilliantly trained scientists who deliver high quality measurement and have high standards and values, beliefs and behaviours to deliver healthcare to patients. The academy, this is kind of the structure. I'm supposedly the president of the council, although I do sit on the board as well. The thing I want to show about this slide is there's lots of different bits. There's the board, which is kind of the management part of the academy, the finances, the rules and regulations, that kind of stuff, the governance in that respect. And the council is all the professional bodies, and any professional issues come from the council. They can be suggested by the board, but the council will decide what they are, and the council are your professional bodies that populate that. On the right-hand side in sort of reddish, that's the regulatory side. And the regulatory side has actually very little to do with the main part of the academy, because we can't actually set the standards and then regulate the standards as well. It is actually completely remote, and you'll see the regulation council is majority, a lay majority. It is not scientists, it is the public and leading lawyers and various other people. So it's kind of this weird structure. You don't need to worry about this. The point is, regulation up to now has been the big sort of energy, the big work parts of the academy. And the one voice has only recently, in the last 6 months, whilst there have been issues, at the appointment of me in May as the president, has started to grow this one voice. And that's what I'm going to spend more of the time about today. So the one voice is that side of the academy is based on a model of the Academy of Medical Royal Colleges, who you may or may not have heard of. But basically, you've heard of all the Royal Colleges in medicine, the physicians, pediatrics, emergency medicine, occupational, and they're all doctors, okay? And they come together and have one voice through the Academy of Medical Royal Colleges. They've just spoken out about, well, there's a few things here. Quality improvement, e-learning, 7-day acute working, specialty training, standards in patient prescription, so they can have, with all those organisations, one voice to the minister, ministers in all the 4 countries if necessary, or one voice to the media and the public. And that's what our academy has got to become and is becoming. It started. So we interact with our professional bodies, obviously very important, the medical royal colleges, because a lot of the issues about what we require that we actually connect with what the doctors are trying to put together, and the nurses and the allied health professions. We can't be scientists in isolation. We have to be in there leading with everybody else, making the changes to healthcare that we've got to have in this country. And you've heard that many times, and the reason for that is because the NHS is the victim of its own success. It has been superb. When it was launched, people generally retired around about 60, and most of them wouldn't live till 70. Now it's pretty normal for people to live to 85, and it will be extended beyond that. So the NHS that was designed 60, 70 years ago doesn't fit with our modern life and our modern health that we all have as a population. We obviously interact with the National School, who are very important for all of you in you getting your qualifications at PTP, STP or higher. And we also interact with the regulatory bodies, the Healthcare Professions Council, and I'll come back to that in a moment. This graph hasn't quite worked out the way I wanted it to, but I want you to get an idea of, in blue, if we go from Band 2 to 4 assistant, practitioner Band 5, 6, STP scientist Band 7, consultant 8 and 9, what used to happen in blue is that we had a lot of people around about Band 5 to 6, and not many practitioners at the low end of the scale, and not so many at the high end of the scale. Now, this isn't a perfect diagram, but what it does just give the message about is that we're shifting the way that we're designing our services. We need lots more people at the lower end here, and by low I don't mean that in a derogatory way, who are at the coalface delivering diagnostics, delivering therapeutics in large numbers. And you need, at the upper end, people doing the reporting and much more doing consultant roles in parallel to medical consultants, or perhaps even surgeons in some cases. So we've got this shift from what I called an incisor to a kind of molar shape. There's a bit of dentistry, eh? Just to get that shift that's going to happen in our workforce. And some of the professional bodies have been monitoring this, and it's beginning to happen, beginning to see that change. The Academy's job is to influence a lot of people, and the most important people that we influence is the great British public. I say public because it's not patients, because our job isn't only to sort out the diagnosis of disease or abnormality and to treat it, but it is also to prevent the public becoming patients. So by offering our services of screening to see that people are staying within limits of cholesterol, or checks for diabetes, or checks for asthma, or checks for a whole host of conditions, that depends on having good scientists doing the diagnostics to high standards to make sure that people don't become patients. We clearly have strong links with the Chief Scientific Officer. In fact, three of the four scientific officers were at the Congress on Monday. That's Chris Morell from Wales and Karen from Scotland as well. We don't yet have a Northern Ireland one. But we have to interact with them because they are the link between the civil service, the professional bodies and government, the minister that makes all those decisions. So obviously we have a very strong link with the CSOs. We should have our links with Parliament as well, because we need to influence ministers directly, and as I say, we've already met one minister in the Scottish Parliament, and I will meet others as well, because we need to influence them to think about healthcare scientists in all these new models. We had an election year this year. We should be influencing all the political parties as well, because whilst they may not be in power, there are certainly lots and lots of meetings within Westminster or within the Scottish Parliament or within the Welsh Government where issues need to be discussed. And if your local MP is Labour or Conservative or whatever, that they must understand the healthcare science issue. So that's some area we've got to build on as well. It means being a bit more savvy and a bit more grown up. It is essential that we do that in the long term. Obviously, the strongest link is with the professional bodies and the regulatory bodies, and that goes without saying. They are the absolute core of the influence we have, and these arrows are two-way. They influence us as well, to remember. Scientists in all the 4 countries. It's not just about England, even though we have 52 million population to serve. And I think we heard on Monday Scotland has 7 million to serve. Nevertheless, we need to interact with the scientists in all those countries and make sure it all links up with the Parliament and the civil service side of things. The private sector as well, because some areas of science, it's part NHS, it's part private sector, and we shouldn't be delineating between those. It's not our job. Our job is to deliver in whatever form, high quality, good standards of practice. And the media, we need to get much more savvy with the media so that we can, first of all, react when there's a story. For example, in the first few months I had the Post, there was the announcement of the BMA, the 7-day working idea. And the BMA made a statement about that. So the government made a statement, the BMA countered it, and we got in touch with the BMA and actually have a link with them to say that if you increase junior doctors' hours, that won't solve the problems. You have to have more diagnostics and more pathology. Who from? The experts, healthcare scientists. So it's got to be a team effort. And finally, the Medical Royal Colleges I've mentioned, we're making great inroads with them. Actually, they are looking to healthcare science to help them with their problems. Because if you think about it, you keep hearing it, that the doctors are coming through to a point in the next 10 years when so many will retire, there won't be enough to replace them, and there's more and more work happening. Something's got to change in the way that we deliver healthcare, and I believe part of that is using healthcare science. So, as I say, I'm going to stick really today about the one voice side of things, and that one voice was in all those areas we've just seen. One of the things we're not very good at is planning as scientists in an overview sort of approach of what's going to be the problem in 5 years, 3 years' time. What's going to be on the Today programme or the BBC News or a documentary. And we need to set up working groups thinking about how we deliver innovation in the community for all the different areas right across healthcare science. We need to think about chronic diseases and demographics and how they're going to change. We're going to have, for example, because people are living longer, they're going to, genetically, we're designed to probably keel over around about 30. Well, that's a bit depressing, isn't it? But because of our modern lifestyle, because of all our innovations, we actually live, as we said, to about 85 or maybe beyond, most people. So that demographics means because people are living longer, they're going to get arthritis, they're going to get immunological changes, they're going to get all kinds of diseases, respiratory, cardiac, diabetes, etc. That's going to become a burden unless we actually tackle those. Global warming, you've heard a lot about that this week with all the meetings going on worldwide, and that's going to have an impact on our health. If you think that if the climate changes, we get more floods, we get more drains flooding out, there's risks of cholera, there's risks of other diseases. If it gets warmer here, you might start seeing mosquitoes coming over here and bringing other diseases with it, which we don't plan for and think about and work on these things. We'll just be caught short 5, 10 years down the line. The obesity epidemic. Now, as scientists, that covers lots of areas. My own area is respiratory and sleep physiology. So someone who's obese is going to have obstructive sleep apnea and will need treatment. And there's scientists to diagnose that and to treat them and monitor them over time. They will also probably have type 2 diabetes, so they'll need their HbA1c measuring regularly and accurately. They will need monitoring. They might need an artificial pancreas and all the technology and support that healthcare scientists will provide for that. They'll need the cholesterol, and so it knocks on. There's all sorts of issues around about a single health problem. We can't think about a respiratory disorder anymore, or a cardiac disorder, or a diabetic disorder. Patients come with a little bit of everything these days, and we need to be able to manage the pathway and the comorbidities. Personalised healthcare, the whole genomics project, actually targeting treatments because certain genetic makeups will only respond to a medication and others won't. This is becoming the way forward, and that actually should save money because you're not doing kind of a blunderbuss giving everybody drugs in the hope that 30% of them actually recover from whatever the problem is. And we've mentioned already the 24/7 working. We were already doing that, Mr. Hunt. But we actually need to make sure that we have robust systems in place. Now, in my own area, we've thought about this and we thought, oh, well, we'll open up on a Saturday and a Sunday and that'll solve 24/7. And then the local hospital in Coventry got in touch with their patients and asked them, would you like to come in on Saturday and Sunday? And they went, would we? How? I've got the match Saturday afternoon. I'm taking the car in for its MOT in the morning. I'm going to visit the mother-in-law. Well, actually, I might go into the hospital then. No, but you know what I mean? People want their weekends. So they've actually looked at extending weekday hours, 5 till 8 o'clock. Do that 3 days of the week, you've gained a whole new day a week. So these are the kind of things we need to interact with patients and find out what's the best way to deliver our diagnostic and therapeutic services. So as you know, we are made up of the 4 main areas, lots and lots of specialisms. There used to be more than this, and they've kind of got boiled down to this through the what was the Agenda for Change kind of program. But all these areas, we represent about 5% of the NHS, 50,000 plus staff, although that's probably nearer 65,000 we think now. Over 50 disciplines, we think at least 52, maybe more. And we deliver 85% of diagnostics in the NHS. So we are utterly crucial to the success of healthcare in the UK, and we probably always have been, but we just didn't recognise it enough. I'm going to skip that one because it's more complicated than the one I wanted. Okay. So you're quite aware, obviously, of the modernising scientific careers. Some of you are at BSc level, some of you at master's level, and the higher scientific training program run at Mays here in Manchester is starting to come through online now as well. And this is the model, or these are the training schemes that are going to lead through to people becoming all those different profile of workforce that we anticipate in the future. The registration stuff may be pretty confusing to a lot of people. It's been the subject of a lot of, not infighting, but differences of opinion. For PTP, it's kind of straightforward, or it was straightforward. It was the academy, you gain your certificate of attainment, and then you go onto the academy register. Others have developed their own registers, but we're still in negotiation about that. The STP, you gain your certificates in STP, and then you'll get your certificate and go on to the statutory register of the Healthcare Professions Council. The route I came, and the route which may be open for a little bit longer, was the old Association of Clinical Scientists route, whereby route 2, you had a portfolio and an experience. It's a little bit like the STP equivalence pathway, and you submitted evidence in an interview and gained your certificate to go on to the HCPC register. And then we are planning the HSST, or delivering the HSST. It's coming through at the moment. And there you will already be registered on HCPC, through STP probably. And then you'll go on to the higher register for the academy. There is also an equivalence route, which the first one was just awarded in Edinburgh on Monday, of equivalence HSSR, higher scientific specialist registration. So there's a lot of letters and alphabetic spaghetti there and process, but regulation, as I said at the beginning, is about protecting patients. And I don't think we need to get hugely hung up about what all these different pathways are. We just need to make sure that we all abide by the standards of those regulatory organisations. So what does the Academy offer? The Academy offers for you, initially, information. It's obviously got all the equivalences and it's got all the registers as well for your training. It works very closely, as we've seen, with all the other organisations. If you go on the website, Vox is the voice, is the information, and I have to be honest with you, I didn't actually look at it very much before I became president. I did prior to the interview, but not much before. And then I realised what a resource I'd been missing. This is amazing. This has got so much information, and you as STP and PTP students should be going to this website and finding out what's happening in your science, both locally, nationally, and on the big scale in all 4 countries. It's really important. We have Twitter and Facebook accounts, so if you follow those kinds of things, I'm too old to do that. I don't understand Twitter and Facebooky things. My kids tell me I'm far too old. So what can we offer you, the Academy? Well, we can offer one voice with all UK scientists. We can offer involvement with position statements and consultations. That's really important. and we can network with scientific bodies and face up to new ways of working and deliver service. So it really is the sort of driver for how your careers, your profession is going to take off, not in the next 2 years, not 5 years, 10, 15, and 20 years. So, part of the remit was to tell you what I do as the president. And so far, it's been a rather busy 6-7 months. I've met with professional bodies and presidents and chairs of the Academy. I've met with government healthcare science advisors, both in Wales, Scotland and England. I've yet to go to Northern Ireland. I've met the presidents of the Royal Medical Colleges, so they are, as I said, very, very supportive of healthcare scientists. A lot of them will work very closely with your consultant bosses, if you have them, consultant clinical scientists, but they expect and they know healthcare scientists have a very similar training to medical training. Not like nurses and not like allied health professionals. We have a very almost parallel pathway, which I'll come on to in a moment. I've met with the Chief Medical Officer, Dame Sally Davis. It was a bit weird, going to Whitehall, into this Richmond House, which is the centre of the health service, just opposite Downing Street. And you get taken down this long corridor with these massive mahogany doors, and you kind of wonder, what decisions have been made in here over the years? And then you sit about this big, and the CMO calls you in, and she's a haematologist, and she's really laid back and ace, and she says, I love scientists, I work with scientists all my life, what can I do to help you? Result. I met with the medical director of NHS England, Sir Bruce Keogh, and he's very, very aware through Sue Hill of the need for healthcare science to solve the problems. I've started to attend professional body dinners, which is why I've got to ride my bike twice a week just to almost stay normal, but I think I'm losing the battle. But they're very important networking to get to meet, like I've met some of you today, just to get a sounding of what's really happening out there. Because when you're on professional body committees and things, you hear a certain conversation, but you don't actually know what people at the coalface really doing the job, who are slightly despising the boss and making them work too hard, really feel about what's happening. So I think it's really important that I do that. And I go to lots of health conferences and meetings, and this one is no exception. I actually really enjoy this bit. And my hospital is very, very kind to give me several days, I'm not going to disclose how many, because if they ever find out, well, to actually do this work. They value the importance of this. And this is not to show off what I am or who I am or anything like that. This is just how I want to show you actually have it fantastic, in my opinion. So my career started, I'm actually from Liverpool, so I'm from the Northwest. I'm one of us. Just happen to work in the Midlands. Strange accent, really is. None of your nice northern flat vowels, you know, anyway. So I went to Sheffield, I did my physiology and zoology degree. I then got a job in physiological measurement in Newcastle upon Tyne in respiratory. I did my own part-time MSc thesis whilst that on lung function and diabetes. I then wanted to do further work, but there weren't any opportunities, except a job came up at the university in the medical school. I became a research fellow. I then did my PhD thesis part-time over 4 years. And then I got to the end of this sort of education and training, and it was time to cash in all of that. And then in doing that, I took a postdoctoral job first of all, and then I became the head of a lung function department and a clinical scientist, and then a consultant clinical scientist at Birmingham when I moved there a few years ago, and then I've got my research fellowship as well. So this is the investment, that's the payback, and your careers are doing exactly the same thing, slightly different format. I wanted to do a slide of my professional pathway because you've got to think about your career as what you do in the day job, but you've got to think about contributing to your profession as well. All the leaders of our science have had a special training with their professional bodies, and you've got to contribute to that all the way through your career once you've trained. So I started out in the Association for Respiratory Technology and Physiology, as it was called then, a manufacturer's liaison officer on the exec. And then I became, again, picked the wrong straw and ended up being chair for 9 years, 3 terms. I then became, in that work, I was on the clinical physiology group, and that actually became the RCCP, Registration Council for Clinical Physiologists. And that experience, my professional body training, if you like, got cashed in as a partner for the Health Professions Council, Department of Health advisor. I did some work in Europe in the European Respiratory Society, which was an amazing meeting with some of the lead doctors in respiratory medicine in Europe. I'm working with them on one-to-one and round committee tables. And you might think, oh, you're having a great time in Europe. But I've learnt skills doing that sort of professional work that I use in my hospital, that I use at meetings with government, that actually has added to what I'm able to do. And then head of the assembly, which I represented nurses, scientists, and physiotherapists to this international organisation. And finally, not finally, so far, President of the Academy of Healthcare Science, a huge honour. But because I've got this experience, I've got hopefully the right skills, and you need to think about what skills, perhaps not now because you're in the training part of things, what skills are you bringing up in your professional body to be a leader of the future? Because you will be. Because in 10, 15 years, I won't be doing it, and all my contemporaries in other professional bodies won't be doing it. You guys will. So my career was a bit wacky. Started in Liverpool, went to Sheffield, went up to Newcastle, moved down to Nottingham, and ended up in Birmingham. And many of you, I've had a chat with a few today, are doing your STP in the hospital that you got trained at previously anyway, or certainly in the same area. So you don't have to move around. I had to move around a bit. I was an undergraduate in Sheffield. I then had to do, the blue is clinical jobs, the red is research jobs. I had to move around all over the place to get that training, and that's, you know, up and moving with family and all the rest of it. Whereas your future, because of MSc, you still will have to move, depends where the jobs are and everything else. I know, I appreciate that. But you've got this pathway on the right-hand side where you can go from school doing ATP maybe initially, then doing the PTP for 3 years, then perhaps going on to do your master's STP, the ARTP, ARTP2 are just professional qualifications. You'll then perhaps want some clinical experience at managerial level, leadership level, and then you might do your 5-year HSSD to become a consultant. From the school desk to the consultant's desk. That is within your scope, all of you in this room, that's possible. You won't all get it perhaps, and certainly not all at once, but you have a line to the top. My line to the top was all over the country, all kinds of different jobs. It really is set up for you for the future. And you'll see, as I said before, the parallel training for medics. That's why we are so close to medics in terms of how we deliver our services. So you've got the MBCHB at medical school, the FY1s and 2s, the CT training, and then they get a certificate at the top to become consultants. In parallel, we will be doing the same. The highlights of my job, and you will have highlights and you need to set goals to have your highlights. I bet one of yours will be when you get your STP or your PTP, and so it is. For me, doing my job is seeing my patients. Thursday, tomorrow morning, I'll have a sleep clinic. I'll see all my sleep apnea patients, some new patients who need to go on treatment, and some other patients who I've been seeing for perhaps months or years to see how they're getting on with the treatment, how they're losing weight, how the diabetes is, everything else. It's a patient-facing role. I absolutely love it. I love leading my clinical team. I've got a great team of about 15 nurses, admin, and all my healthcare scientists. And without them, I couldn't be here today speaking to you because the business is running back in Birmingham right now. I love doing research. So you've got all the difficult day-to-day stuff, but then every now and again, I'm just going to make that bit of time and do the research project. So my STP third year, we've been working on his project. That's nearly finished. I've got a guy doing another master's degree. He's just done some fantastic research in lung function measurements. And I actually get seriously excited when he comes to me with the data sheet. I mean, how sad is that? But it's just great. We've got this data, and then the next thing we're doing plots, and then we've set a hypothesis, and we've answered it. And I tell you that there is nothing better than that. All the management dross and misery of day-to-day kind of having to do some of the business you're asked to do in a hospital, is countered by something that's really exciting, because we are scientists. We're not nurses that do a bit of research. We're not physiotherapists that do a bit of research. We're not even medics that do a bit of research. We do our job, and science and research is central to that job, and you must always keep that up. I like meeting you guys and encouraging you to become healthcare scientists. I hope that's working. I like presenting at conferences and getting qualifications, becoming a consultant, becoming a chair of a professional body, becoming the president of a professional body, becoming the president of the academy. These are all highlights of your career. It makes my job interesting and enjoyable. And the last one there, I've been able to set up a training program for lung function testing in Europe and also in Africa. So something that we do in our day-to-day jobs. Anything you do now, you could be delivering services internationally using your skills. And you're all capable of this. There will be different opportunities, I'm sure. And publish. You must publish all your career. Yes, your final year project, you'll do an abstract, and maybe you might even get it published as a paper. You have to publish throughout your career. I've got quite a few publications. Nowhere near have I gone into full-time academia. But you need to make sure all your career you're doing research and you're being important, because you are scientists. You can't sit back and just provide a service. You've got to publish as well. And think about your career pathway. The red bit is the actual doing the job. So it might be in some aspect of biomedical science or physiology or physics or imaging or whatever. You do your initial training and you do the job. You deliver the service on a day-to-day basis. As time goes on, actually at that point, you don't do much management, you are managed. But gradually, as you go up the scale, you start to do more management. Management of the juniors, management of assistants and things like that, perhaps. And you do less of the day-to-day routine stuff and perhaps more of the specialized stuff. And then you actually get to a crossover point where the management and the leadership becomes most of your work. Now, you don't honestly believe that I do spirometry, lung volumes, gas trap. I don't have the time to do those measurements, but I have the time to lead a team that does all that. And your career will change in that way. And so all these things I've been saying about, you've got to build up this leadership experience through professional bodies and other experiences. That's the rest of your training and education to be the leaders of the future. It'll happen. You probably can't see it now, perhaps, but it will happen. And your career will always have these three aspects. Sometimes you'll be much more into research. Sometimes you'll just be delivering clinical service. Sometimes you'll be doing the leadership part for your professional body or even within your hospital. And there'll be overlaps between all of those. And you just need to be trained to be flexible and to fit with what is required. And that's what the STP training, PTP training, the MSc courses are really good at delivering. It's making you good scientists, but versatile as well. You have a much better vision of the whole picture of healthcare because of your training program, and you'll go your first year in STP, for example, that you get to see a lot of the hospital, a lot of what works. This will stand you in tremendous stead as you go on down your career. So what are the qualities for becoming a healthcare scientist? A bit late now because you're on the route, but if you were to had some school leavers or school kids actually saying, why do you want to, why would you want to be a healthcare scientist? What do you need? Well, number one, you need to want to care for people. Now, caring for people doesn't always mean face-to-face with them. It actually means that I'm staying late tonight to finish these assays or whatever, or get this process completed, so that that patient who was diagnosed with cancer this morning has a chance of an op in the next week and increases their survival. That kind of caring. It's not always right in the patient's face. Some of the jobs are, but not all. Attention to detail. That's probably why you went into all of this, because you're pretty good at just checking everything, double checking, cross-referencing, making sure that it makes sense. And we're very good at that. Other professions aren't so good at that. We're very good at being accurate and precise. Sometimes you have to work at it, but you can see the different models there of what accuracy and precision is. But that's, again, our key skills as scientists. And always, now and for the rest of your career, ask why. You've got to ask why about everything. If you get a result that doesn't make sense, you've got to ask why. It may turn out that somebody made a silly mistake down the line and did the calculation wrong. It may turn out you've just discovered a whole new disease. So you've always got to be double checking and asking why. Never lose that. It's also great fun. Drives my wife nuts. Finally, caring for people, attention to detail, accuracy. Being professional. That's what you've got to be for the rest of your life. This is equivalent to being a doctor, a medical doctor. I think it's better personally, but that professionalism you will take for the rest of your career, and you've got to carry on wanting to make a difference because you can. There's not many jobs where you can do your BSc or MSc and carry on delivering that service and making a huge difference to people's lives. So, be proud that you're a healthcare scientist. Always uphold the standards, qualities of good scientific practice that are central to your training. Support and promote your profession at home and in the public and at work. Christmas is coming. Tell your granny about how good you are as a healthcare scientist and the job is, if you happen to see her over Christmas, or your cousins, or the next door neighbour, or the milkman. You've got to give them a tip anyway, so you may as well. No one has a milkman anymore, do we? Sorry, the postman. But be passionate about your career. It really is. There are a lot of really average jobs out there. You have a fantastic job and a career. Don't ever forget it. Life, as we found out in Paris last month, can be very, very uncertain. We don't know what's happened or going to happen. And all of us need to take our opportunities to be brilliant. You are all brilliant from all backgrounds. It doesn't matter. Carry on being the best healthcare scientist that you can be. Thank you very much.
Okay, thank you. Yeah. Thank you, Brendan, for that really inspiring talk, and I'm hoping everyone can take something away from this. We've got time for just a few questions. So if there's anyone?
By the way, if you're worried about asking a question, I'm more worried about answering it. Is that all right?
So thank you for that talk. I think we all quite enjoyed it. I just wanted to ask a bit about the Academy and how much impact do you feel we're having on government decisions at the moment, and do you see that progressing and it being a stronger voice in the future?
I think the problem has been that whilst there were certain issues in certain areas of healthcare science where the Chief Medical Officer or the Minister for Health has asked about a specific project, and then they've had to find out probably through the CSO's office, Sue Hill's office, who's the best people to speak to. We're now starting to go to them and saying, hello, we're here, we've got lots of people, and these are your top 5 problems, and we can help with all of these. So the impact is coming. Already in the last 2 months, we've got a list of things we've taken to the Chief Medical Officer, Dame Sally Davis, saying this is where we can help on these projects. One other thing, they've come to us now and said, we want to expand prescribing for healthcare scientists. Because some of you, it would be really advantageous if you could be allowed to supply and administer, not full prescribing, but supply and administer a drug for a test that you're doing. Or, for example, if you were doing a cardiopulmonary exercise test and the patient who had angina started to get some chest pain, you could administer GTN. The patient could as well, but sometimes they forget it, but you'd be able to administer that. Or a bronchodilator for an asthmatic, you could administer that. So it makes it safer for the patient. So for the first time, they've come to us as the Academy and said, can you help with this? And we've got 7 professional bodies have all supplied that. So yes, we're starting to make an impact. This is only the beginning. It's going to be more and more and more.
Any other questions?
Just a sort of last question, if no one else has got one, then could you just sort of imagine yourself in our position, what would be the single piece of advice that you'd give someone starting out maybe in the first year or 2 of their career?
Just as I said, the brilliance bit, just stick to being good, just stick to constantly that training you've had to always question, always check if you've done something and got an unusual answer, can you explain that, that result? And just stick to your good scientific principles and you won't go very far wrong at all. All the regulation bits, all the qualifications, they will flow. It's about you personally believing in your profession, believing that you are a good scientist and working to that. That's the best advice I think I can give you. Oh, and have a happy Christmas. That was the other bit, yeah.
Okay, thank you.
Okay, thank you all.